Good evening, guys. This is about take 3. I tried to do this earlier and the recording didn't work. So here we go again. I'll try it one more time. Anyway, this is the PEOP. I'm going to record for you and I'm going to get started now. There were 4 additions to the PEOP. It started in 1991 with Charles Christensen and Carolyn Baum. They updated it in 97, in 2005, and then finally in 2015. And Julie Bass was an addition to the authors. So Carolyn Baum says that the PEOP model organizes knowledge so that the occupational therapist has a unique perspective to view the environment on a personal, population, and organizational level for a client. It was ahead of its time. So if you notice that those terms sound familiar to the OTPF, and our OTPF language comes from quite a few of these historical models. So there's a lot of the terminology is mixed in from years past. So some of the theoretical foundations for the PEOP includes general systems theory, environmental theory, neurobehavioral theories, and social and behavioral psychology. And there was a particular influence from the personality theorists, especially Maslow. And if you notice, there's quite a few different types of theories here, and pretty typical for all of the models that they chose. Usually an environmental, sometimes developmental, or kind of a psychological, and some form of social theory as well. So the PEOP has an ecological transaction in it amongst the person and the living environment. So this is not to be confused with the PEO transactional connection. The transactional piece of the PEOP is only between the person and the living environment. The overarching PEOP is interactional, but not transactional. And it is systems-based approach, which means that it is top-down, and it's looking at what is affecting the client from a broader perspective that has gotten the client to where they are. What supports them, what is limiting them, and specifically, they're very specific about the client, putting the client in the center of this model. It is also a very global model, looking at the healthcare perspective. Occupational therapy is seen as the bridge here between diagnosis-based care and sociocultural level of care. They felt like that occupational therapy was relevant to everyday living, and with OT in the picture, it changed it from more of that sterile medical model to a more personal client-based model. The foundations of the model, it started with the International Classification of Functioning, so the ICF, and that again, very similar to the OTPF. You'll see a lot of similarities, and I showed that to you in class, especially in the occupations area, but just remember that the ICF is bottom up and the OTPF is supposed to be top down. It still has, that's questionable, but it is meant to be top down. And this PEOP, when it was born, or however you want to say that, fit the new paradigm of individuals, populations, and organizations. And it does fit across the post-acute continuum of care for all settings. You can use this in any healthcare setting, inside or outside hospitals, communities, organizations, any type of social context, pretty much anywhere this model can be used. It's one of my favorites, actually. It does look at 3 domains of care, meaning that overall the outcome that they are seeking with this model is performance, participation, and well-being. And what they say is when everything is in sync, that's what is the outcome of the model. And so here you'll notice we're going to start talking about the areas that you'll find on the table that is in the Google Doc. And so this is the summary of the focus. And this is what they focus on here is how the person, environment, occupation, and performance interacts together, and their related factors contribute to occupational performance. So if you notice when you look at the picture or the template, there's 4 circles, and we'll look at those in a little bit, and I'll explain that a little further. Then there also the occupational challenge is influenced by both the person and the environment. And if the occupational challenge is just right, then and there's not a dysfunction in the person or the environment, then there should be the just right fit. But if any of those things have dysfunction in them, then there would not be a good interaction. And occupational performance is the outcome that we're looking for, and it equals the interplay of the variables. So there's reciprocal action or interactive action, and then that's plus the occupational challenge. And so the interplay of the variables, that is the person, environment, and occupation. Okay. So our essential components of the PEOP, you have first of all, the PEOP is actually, it has 2 parts. So it's got the process, which is similar to the OT process. And this is one of the few that actually has their own process. And that's another reason why I like it. But the narrative story comes first. And then you've got the pieces and parts of how you break up the client. So the narrative story tells you all about the client from where they came from, where they are now, and where they want to go, or their goals. And then other essential components are the person factors, occupational and environmental factors. And there's more variables below each one of them. Here you can see how the PEOP is broken down into a process. You've got the narrative that comes first, then it shows assessment and evaluation, and then intervention, followed by outcomes, and you can see the arrow goes down and around and starts over again. So we were going to break it down and go through all the different pieces of the narrative, the assessment, the intervention, and the outcome. Very, very similar again to what we see in our OTPF. So when we're looking at the narrative, you've got the past, the current, and future perspectives of the client, and you'll have their interests and their goals, and then you also have whatever their goals and needs are that are unique to their person, the organization, and the population. So here you're seeing a difference in or an additional population and organizational level to this model, so that you can actually use this for a needs assessment if you were looking at doing something similar for your capstone project. If you needed to do an assessment of an area or a facility or something like that, you could use this process from the PEOP and use it as your framework. It would work out pretty good. Then when you look across, you see the person is next, and it's broken down into the cognition, psychological, physiological, sensory perceptual, motor, and spirituality and meaning sections. And then you've got occupation, and it's broken down into activities, tasks, and roles, and then classifications. And then you've got environment, which is broken down into cultural environment, social support, social determinants, and social capital. And then there is health and public policy, and physical and natural environment, and then assistive technology. And then if you look down here at these egg-shaped circles that are kind of on top of each other, the picture of that is kind of that they float back and forth and they are interacting with each other. So to make them the right fit, and what you could see is where the person and the environment are sort of floating over the occupations and the performance. So they're all interwoven or interactive, and if one of them is out of sync, then it makes the others out of sync. So it's kind of like looking at I don't know if you've seen those those metal balls that go back and forth when you clank them. You hit one and then it hits one out on the other side. That's kind of how that works. So if reciprocally, if the environment is not just right, then it would cause the person to be out of sync. Therefore, their occupational performance would not be where they're wanting it to be. And then that means that it would upset their participation and well-being. Lots of words. Okay. And then the arrows going back and forth here is just showing that you are continuously having the conversations about their narrative. So it'll change. Okay, and here's another breakdown with the narrative. You're looking at when you do a narrative, you start with the subjective data. You're asking them questions. You're taking a perception of the situation, and you're going to find out what their desired goals are. And through this, you're going to determine if they need OT. Maybe they've figured out what they need and they don't need OT anymore. Or maybe you feel like you need to show them a little bit about what you can do for them because they may not know. Then in this model, you have intrinsic and extrinsic factors, and the person factors are your intrinsic factors, which are your psychological, cognitive, physiological, spiritual, and neurobehavioral. And these can either support or limit occupational performance. And you have occupational factors, and here they're broken down into activities, tasks, and roles, very similar to the ICF. It's where you see that. And then the occupations are what people want or need to do. Participation is defined as active engagement and involvement in occupations that contribute to well-being. And then occupational performance is the culmination of doing occupations through the interaction of a person's factors, intrinsic, and the environment, extrinsic, and supports participation and well-being. So you're looking at the participation here and the engagement the participation and well-being are part of the outcome of occupational performance. Okay. Then you've got your environmental factors, which are your extrinsics, and you have cultural, social determinants, social support and social capital, education and policy, physical and natural, assistive technology, and these may enhance or limit occupational performance. This is where you see more of the systems theory come in, so you can kind of see how they have it set up to where if you look at it, your social determinants are sort of hanging out there a little in the meso area rather than more distal than proximal. Same with like education and policy. That's more exterior to the person than the direct physical environment. And then you have assistive technology, which if they have it, it could be support. If they don't have it, it could be limiting to them. Okay, so this slide has the assumptions on here, similar to the assumptions that we learned about in class the other day about theories and what assumptions mean, where you can't really prove them or measure them. It is more about a belief. So that's what these developers, this is what they wanted to show that would come out of their model. And one of them is that health is personal to the client and must be experienced to be understood. The other is the client determines the outcomes, so they're very client-centered. And then the last one is it begins with the interview or narrative. The next assumption is that occupational performance supports participation and well-being. So according to the desired roles within the environment, their participation and well-being is supported through occupational performance. Their outcome is unique to the relationship of the person, occupation, and environment. So no two people are the same, and each person has their own set of values, beliefs of how they want to or has their own set of beliefs or visions or goals or what occupational performance looks like to them. The next assumption says occupational performance is an outcome of a dynamic process that leads to participation and well-being. Kind of says the same thing, it's just saying that it's more of a dynamic process here. And that the person, occupation, environment are reciprocal, interacting and influencing. So that's very important to remember, probably something you want to write down because this is different from the PEO. The PEO is transactional. This one is reciprocal, interacting and influencing. And remember, earlier I said the only things that were transactional was the occupation and, I'm sorry, the environment and the person within this model. Then a person's context and occupational preferences help to shape the goals for their performance, participation, and well-being. So where they're at, what they're doing, what they want to do, that's where you're going to get your goals because that's what they're motivated to do. And they believe that client-centered practice is necessary and foundational. So that's why they make sure that the client is the center. And then when we talk about function, that is when there is a person-environment fit that is congruent with the client's needs and capacities and reflective of his or her desires. So the client is actually able to do what he or she wants to do, and it works well for them. And then when they do that, some of the outcomes that come out of this model include participation, role performance, an identity or realization of self, life satisfaction, happiness, and well-being. On the other hand, dysfunction could happen, and that is when their occupational performance is limited or restricted, and occupational competence is not achieved. So that would mean a lack of goal attainment and participation in activities. So when a person can't perform their roles to the level of their own satisfaction or their competency level, then it is dysfunctional. There could be conflicting demands for roles, like maybe they wear too many hats in the family and they're not able to get them all done like they want to. So that could also cause dysfunction. Sometimes people are put into situations in their culture where they have to do certain things and it's overwhelming. So how do we get them to change? What makes them want to change? Well, they first have to be motivated. So they have to have a desire to change. And they need to desire or to want and or be willing to explore their environment and demonstrate mastery within it. And that's called human agency, demonstrating mastery within your environment. It needs to be activated to enhance motivation. So once they start getting it, then they want more. They'll experience accomplishment. Once they get that trophy, they'll want to get the trophy again. Um, and so that just kind of makes a cycle. Okay, then assessment guidelines. So we have to figure out what exactly it is that's going on with them so that we can figure out what exactly it is we need to do with them. And the only way to do that is to do a true assessment. And the way you do it with the PEOP is from a top-down approach. Just because it's a top-down approach does not mean that you're not going to do what needs to be done with your patient from a proximal perspective. So if a patient has let's say you're in a hand clinic, a patient has hand surgery, we know going in we're going to work on that hand. But when you do their initial eval, you've got to get that narrative first so that you can establish who they are, what is going to get them motivated and ready to work with you and to get them back to wherever they need to be going. So anyway, and to do that, you can use standardized and observational screenings. You would be evaluating their intrinsic factors in the environment, what's going on there, is it safe, can they even get around in the environment. You would do a task analysis. You would look at what activities they are doing and look at it from beginning to end to see what problems they might be having. Let's see. So you want to make sure that you are assessing all the performance components and identifying which ones are not congruent with the client's ability. And then you would write up the summary of the strengths, things that they are doing good or their supports, and then the problem areas. And the problem areas, that's where you're going to write your goals from. And so here are some assessments that they recommend is the COPM, which you will be seeing. I believe the CMOP group is going to be doing the COPM with us. MOHO has some assessments that we can use, and then the activity card sort is also another one. Some interventions, they appreciate the restorative benefits of occupational performance, and it does it helps because they use occupational performance as a means for them to get better in the areas in these areas here, such as controlling movement, modulating sensory input, maintaining physical health and fitness, and maintaining cognitive skills, increasing motivation to develop personal identity, well-being, self-efficacy, and just enhancing overall personal meanings and collective or shared meanings. Other things that it does is that it helps to recognize the role of the environment as it impacts a person's health and participation in meaningful activities. It also enhances occupational performance by structuring occupations for meaningful participation and competent mastery. And so what they're saying here is that occupation as a means does help improve occupational performance. And you can do that through adapting or modifying actions, tasks, and ultimately one's occupations. You can teach compensatory techniques when appropriate, foster temporal adaptation. You could, what that all that means is breaking down the time factors, teaching them how to time manage their activities and that type of thing. You can work with them on their roles and how to be more efficient with what they do, maybe say no to some things because sometimes they have too many things that they need to be doing. So just looking at their routine and seeing what's going on, help them figure out what they need to find out what's important. Okay, here's a case study on Barbara. She's a little lady, 72 years old. She lives alone and she has some family nearby. They think that she possibly has a chest infection. She was admitted to the ER. While she was in the hospital, she fell and had a fractured hip. It was operated on, and she is staying in the acute care orthopedic floor, or staying on the acute care orthopedic floor, and being seen by OT and a rehab team. So because of the scope of the service that they're working in, an orthopedic OT's goal would be to get Barbara back to her home in the community, safe and sound. In order to obtain the information necessary to create Barbara's version of the PEOP model, the following assessments are used. The CAM ICU confusion assessment method, and it would be used either with the normal or an acute ICU version. Then there is the Canadian Occupational Performance Measure, the Barthel Index Measure, and they were going to do a home visit incorporating the Safer Home tool. The use of the CAM ICU was for quickly assessing the mental state, and the NICE guidelines were for stating whether hip fracture patients over 65 were at high risk for delirium. If they were possibly high risk for delirium, they would need to refer her to a doctor or nurse for further investigation of any underlying chest infection, dehydration, or pain. So we're moving on and going to assess her occupational performance using the Barthel Index of ADLs with the activities of washing, dressing, feeding, stairs, and transfer tasks. And doing this, we would be working with the physical therapy and the nursing teams. Also using a semi-structured interview tool, the Canadian Occupational Measure. And we're going to use the COPM for identifying any areas of occupational importance to Barbara and what her current satisfaction level is with them at this point. If for some reason she wasn't deemed to have the capacity, the mental capacity when they did the CAM ICU, they can still use the COPM and just ask the questions from a proxy or family member, or even the healthcare staff. Then they were going on to assess her home environment where she'll be returning, and they were going to do a home visit or they were going to have to refer to the community OT, early supported discharge team, and possibly use the Safer Home tool to help them guide their assessment, and they would need to clearly document the limitations and risks. So if appropriate, they would offer early supported discharge, and Barbara could complete the rehab at home. This would involve visits from health professionals and equipment loans and a social work package, uh, and then if the family is unable to help, um, they would be able to get that social work package then. So some areas that are highlighted on here are some areas that reflect the types of interventions carried out, and also some of the assessment areas. But for example, from feeding and mobility assessments in the Barthel Index of ADLs, Barbara has poor lower body strength and cannot fully weight bear for any length of time without pain, but is able to independently cut, prepare, eat food, and eat food. And then from information that they gained from the COPM, Barbara reports that she is satisfied with not cooking. She sounds like me. Not cooking a hot meal every day, but she's used to preparing simple meals since she was a widow and having hot meals only when she gets around her daughter. So therefore, the stool in the kitchen is really not necessary for long periods of standing. However, difficulty in rising from seated position due to restriction on her hip flexion beyond 90 degrees and poor lower body strength, that uh, meant a frame was offered to provide support when she was getting up out of the chair and out of bed and off the sofa, off the toilet, um, and anything else that needed to be raised up. Okay, so now what we would look at is this template here with the picture, and we would take all those things that are highlighted and try to put them in where they go. So anything on the past two slides you would look at and try to fit in to the person, the environment, the occupation, and the performance. And so what I want to show you here, we are looking for congruence between all four. And you can see the overlap here between occupation and person, and environment and occupation. You see the overlap, and performance and environment, and performance and person. And all of those overlaps are the same size, so it's all in sync there. So if it weren't, with some of her problems that she's having, we noticed she had some uh, fluctuating memory problems. So let's just take that one for example. Do you think that her cognitive status would be a limitation for her right now as far as how she would perform her occupations? I would think that that probably would be the case. Is the environment she's in right now, is it limiting or supporting? I would say that it's supporting because of where she's at. She's got lots of hospital workers there to help her. And now when she goes home, she won't though. Okay, and like this says, she lives in town in a flat, man-made surfaces. Wood flooring is in two-story home, and there's a bedroom upstairs. And that's her bedroom is upstairs. Okay. So as you could see, we talked about what's going on with the person and their performance. So that's going to be out of sync there. And then if there was something else, like maybe one of the tasks needed to be broken down because it was too difficult, then this area between occupation and person would be a problem. Maybe she couldn't get around because she has her hip precautions now, so the environment she wouldn't be able to go maybe do the laundry, so that would be an area. So all of those different things would cause a limitation, and the reciprocal movement would no longer be smooth, and so it would impact her ability for occupational performance. Hopefully that makes sense to you, and we'll talk more in class too. Okay, so then here's the resources, and that is all about the PEOP. Hopefully you got a little bit out of it, and I apologize for it being so late, but it took me forever to get it recorded, and hopefully this is going to work. So I am about to do the PEO. Have a good day. See you guys tomorrow.